Okay, good evening, everyone. A very, very warm welcome to our second YO-IFOS webinar. We are so grateful to everyone joining this evening. We're very excited. We've got some wonderful speakers who have put aside some time to be a part of this global initiative. We've got quite a lot of people on the call. Just some house rules. Kindly mute your microphone on entering. I have muted everyone as far as possible, but I do need to allow the speakers to unmute themselves. For the purpose of tonight's presentation, one of our speakers, Professor Patel from Standford University, has some other clinical commitments, so we'll try and let her go first, and she may need to excuse herself a little bit earlier than expected, but I'm sure we're going to have an excellent webinar. So just a request, if you wouldn't mind, if you have questions towards the end of any of the presentations, please raise your hand so that we can be aware that you have a question, and then I'll allow you to unmute your microphone. Perhaps you can also, if you have registered, that's amazing. If you haven't, maybe you can just pop in the chat function to say where you're from and where you're joining us from. It's a real privilege from the UCT ENT team to be able to host this and to have all of you with us. And we see we've got a very large amount of people that have joined already. We've got around 80 participants. So I think that without much further ado, we should start the meeting. It is now 7:05. And from a UCT-Africa perspective, welcome everyone, enjoy the presentations. I'm going to invite Professor Pierre from Red Cross Children's Hospital from UCT affiliated, who's the Executive Committee Chair of YO-IFOS. I'm just going to ask Shazia if she wouldn't mind to give us a bit of a brief introduction and just share some information about YO-IFOS to kick off the meeting this evening. Shazia, over to you, if you wouldn't mind to share your screen and just say hi. You're currently muted, Shazia. I've allowed you to unmute yourself. You can try now.
Excellent. Thank you. Thanks, Louisa. Thank you for putting this together. And I want to basically say good evening and greetings from Cape Town to everybody who's joining us, and a warm welcome and good morning to those of us joining us from the North Americans and the South American areas. I'm so excited to do this second collaborative educational webinar. And the reason for this is because we've had a very successful first webinar a few months ago. I welcome you from two spaces, the first being my hometown, Cape Town, where I work and am a consultant and associate professor at the University of Cape Town, as well as the YO-IFOS Educational Committee, which I share the leadership together with Dr. Francois. And so today we've got an exciting lineup. We have some wonderful speakers, and they are from such diverse locations that it's an absolute wonder that we managed to get everybody here together. Before I give the platform to Dr. Patel, I'm just going to tell you a little bit about YO-IFOS for those of you who don't know or who may not be familiar with the organization. It was established in 2017 in Paris at the 21st IFOS World Congress, and it basically is a breakout young physicians group. It's aimed at young physicians who are otolaryngologists who have an interest in having an academic career or want to pursue education and training platforms. It does represent all regions and all subspecialties. And we currently have leadership from Dr. Nicolas Patry and Dr. Natasha Tessier until the next YO-IFOS meeting. There are 4 committees: the Network Committee, Research, Education, which we are managing, as well as the Congress organization. Please, if you're interested, join us, visit our website, and just find out all the wonderful things that is going on and that you can be a part of. So please feel free to visit us and join. So onto our agenda for tonight, or rather this morning, for those of you joining us from North America. I'm going to introduce our first speaker, Dr. Zara Patel, who's going to speak to us about the techniques to address sinonasal tumors, or infections of the frontal sinus. And for those of you who don't know, Dr. Patel is an expert in advanced endoscopic sinus surgery. She's also the associate professor and as well an associate professor in the Department of Otolaryngology at Stanford, as well as a professor in neurosurgery. She's, together with that, the director of the endoscopic skull-based surgery unit at Stanford, and the program director of the Rhinology Fellowship, which is why she may be rushing off if she has to go back to the operating room. I just want to add one of her notable publications that basically had us all frantic last year with regards to COVID was this letter that she'd written out and was subsequently published in the Journal of Neurosurgery, which for me was a landmark paper, and I'm sure for many of you all over the world used this before COVID hit us. And so we're very grateful for putting that out and for all of the work that you've contributed in the COVID, the fight against COVID. So thank you very much for that. Without further ado, I'm going to hand the platform back to Louisa so that Professor Patel can move ahead. Thank you very much, and I look forward to your wonderful talk.
Thanks very much, Prof. Pierre. Prof. Patel, I don't want to hold you up anymore, so I'd like us to get going. Prof. Patel, please would you mind to say hi and also just to share your screen and just make sure that everything's running well. Your screen looks great. Your screen looks fantastic. Can we perhaps just go to your first slide?
Yeah, there we go. Hi, everyone. Thank you so much, Shazia, for that wonderful introduction. And thank you, all of you, Louisa, and the rest of everyone at UCT and the YO-IFOS organization for asking me to come and speak with you guys. It's an honor for me to be here also. And again, apologies that I'm in the middle of my OR day, so I'm going to have to run after I do this, but I definitely will stick around for any questions at the end. So please feel free to ask whatever you want at the end of the talk. And so as they mentioned, I'm going to talk about addressing tumors or infections in the frontal sinus. And when I started putting together this talk, I started by thinking more about tumors because these are my disclosures, but none are relevant. I started thinking more about tumors because, as mentioned, I'm the director of endoscopic skull-base surgery, and so I do a lot of tumors within the frontal sinus and skull base. But then I sort of thought more around the terms of who I would be speaking to, and I know not everyone here is going to be taking out big tumors from the frontal sinus and the skull base, and so I think that the techniques that we use to address tumors are also the techniques we use to address bad infections. And so I'll touch a little bit on specific tumor pathology and what we need to think about, but I will spend most of my time talking about sinusitis and how to make sure that we're addressing the frontal sinus well when we have infection or inflammation in that area. So just to start with this little slide here, this is an example of a very classic inverted papilloma that has developed right within the frontal recess and gone up into the frontal sinus and down into the ethmoid cavity. And you can see that the things that I'm thinking about when I look at this type of imaging that you should also think about when you start thinking about how you're going to address tumors in particular that are within the frontal sinus is, first off, in this superior picture here, how far lateral does this tumor seem to be going? And I'm showing you MRI pictures because if you just have a CT, it's not really going to tell you what you need to know. You're not going to be able to differentiate the gray tones well enough to know what's just, blocked secretions versus tumor. So you definitely should get an MRI if there's any suspicion, if there's unilateral opacification in a process going on. I would always recommend getting an MRI to investigate that further. And then as far as knowing how far lateral you're going to be able to access endoscopically, we really use the mid-pupillary line. So if there's something that is medial to that, I will definitely be able to access that and get all the way around it endoscopically, whether it's via a regular frontal sinus sinusotomy or a draft 2B or a draft 3, and we'll go over all of those techniques. But that's going to be pretty simple for me to get to. Once things start going more lateral than the mid-pupillary line, it really becomes much more difficult to make sure that you have completely accessed and gotten around the entire tumor, especially on that inferior aspect on the roof of the orbit. It's much harder to see endoscopically at that point. And then also, you are kind of basing your approach on luck if you're going endoscopically, thinking that it's not actually attached at that position and that it's just growing up into that area and you'll be able to pull it down, which is never a good way to go about surgery. You should have a plan and not depend on luck, although many of us are lucky many times, thankfully, as well. So that's that part to consider when you're thinking about tumors in the frontal sinus. And then when you're looking endoscopically, that can also help with your approach and plan. So I've just put some of these corroborating endoscopic pictures as to what this tumor looked like endoscopically. You want to see, this is me looking on the left-hand side where you can see where it's coming through on the superior septum medial to our middle turbinate. So that is important to know that that entire superior part of your septum is involved with tumor and it has to go. And then also looking down and inferior along the septum to see how much of the septum may be involved more posteriorly along the areas of, for example, the olfactory epithelium. How much of that are you going to be able to preserve or not? Because that's going to be able to allow you to counsel the patient much more effectively. When you're doing a regular draft 3, you shouldn't be losing olfaction. That should be something that is preserved. But when you're doing it for a tumor surgery and the tumor is involving the cribriform itself and the entire olfactory epithelium, then that's going to be a very different counseling conversation that you have with the patient preoperatively. So those are things to think about when you're addressing tumors in this area. What about, so just as an example, I've put a little video here. This is an esthesioneuroblastoma, and you can see that definitely the tumor is going up and through, going intracranially. You can see the top of the frontal sinus is actually just blocked, but the inferior aspect of the frontal sinus is actually involved in tumor. And so I'm just going to show you here how I would go about addressing that. You want to make sure that you have a really nice clean margin at septum. So you're going to definitely take much more of normal tissue. You're not going to try to go really close to the tumor along that septum. You're not interested in preserving any sort of olfactory epithelium or preventing a leak. In this case, you're definitely going to get a leak. So just take as much as you need to have an oncologic resection. Now you can see we're taking out these inspissated secretions from this blocked sphenoid sinus now that we've kind of debulked the tumor going up to its attachment at skull base. And now you can see that I'm coming up around the anterior portion of the tumor in the frontal sinus. So performing a draft 3 to just get around the anterior aspect. And now completely delicately bringing it down off of those frontal lobes, bringing olfactory bulb with us because that's obviously involved. Taking out the crista galli, that's an important key component of doing an esthesioneuroblastoma surgery, especially one that's transverse both sides. And then finally, removing that inferior portion of the tumor. I put this little piece of Surgicel right up against the parenchyma just to encourage scarring and prevent any intracranial bleeding from small vessels that may have been pushed upon during that procedure. And now you can see I'm raising this flap, and you can see that my nasoseptal flap actually is being brought all the way across the nasal floor because this defect that I'm left with is really orbit to orbit. And so I don't know if you missed that at the end. I'll go back when I right there. This is basically leaving that flap. That's just really the septum and nasal floor on one side is wide enough to cover orbit to orbit when you're up at the anterior skull base. So that's how you can go ahead and reconstruct that type of defect. But now I'm going to sort of switch to our sinonasal inflammatory disease because I think that that's much more common and many of you are much more likely to be dealing with that. And it can definitely involve the frontal in many different ways. And so let's talk a little bit about how to deal with that. Really, when we think about sinusitis in general, I always want to, although I'm a surgeon and love to operate, I always want to go back to, appropriate medical therapy is really where all of us should always be beginning when we're thinking about sinusitis anywhere, even the frontal. And we know that about half of patients are going to do just fine with appropriate medical therapy, and they don't need to go on to surgery. If people fail, then when we do surgery, our surgical success rate is overall very good. It's 85 to 90% of people will do really well and not need to have any sort of further intervention. However, there are some people, that last 10 to 15%, that are refractory to good medical therapy and surgery. And one of the main reasons for that is, as we all know, chronic sinusitis is not just one disease. There's these broad phenotypic categories that we talk about, the polyps versus non-polyps, but we know that that's too broad, really, and that a lot more is going on. We know now much more about endotypes, and that there are complex subcategories of different types of sinusitis that affect people differently. And those types of sinusitis respond very differently to both surgery and medical therapy. So finally, surgery is not a magic wand. I always tell my patients that there's going to be a continuous need for us to do long-term post-operative topical therapy, checks to make sure that you're not relapsing, checking in every once in a while to make sure that everything is looking okay and that they're staying on their regimen. That's part and parcel of doing sinus surgery anywhere in the sinuses, because if you don't do that, you're much more likely to have failure. Of all those sinuses, the frontal is really the most likely to fail. And the way to avoid that is really getting back to basics, really understanding the drainage pathway, those three potential pathways of medial, having the uncinate attaching to the orbit versus attaching to the middle turbinate or the skull base. And just that initial approach and understanding where the natural drainage pathway is allows you to formulate your surgical path and really get to the right place without causing a lot of excessive trauma in the mucosa surrounding it in the frontal recess. Having said that, meticulous dissection is really, I would say, the number one way that you can avoid scarring in this area. And, you know, I've seen a lot of people do sort of brute force moves, really fracturing off the skull base and things like that. And that's not usually the best way to go about frontal surgery. It's a very narrow pathway, and the more delicate your dissection is, the more likely you're going to have success. And of course, managing blood in the field is always something we want to think about in sinus surgery. So just to briefly go over the frontal cells, you know, we used to term these type 1, type 2, type 3, type 4 cells, but now there's a new classification system, which I think makes a lot more sense. We've used for about the last 5 years, this international classification of frontal cells, and it's really figuring out whether you have your bulla and your auger, and whether the cell is suprabullar or supraauger. And that really helps to differentiate, you know, where exactly anatomically speaking this cell is and how it's going to be impacting the frontal sinus drainage pathway. So if you look over here at this top right picture, you can see that this patient has both. This patient has two supraauger cells coming up along the anterior aspect of the frontal sinus, and then a tiny suprabullar cell as well at the back. You can see down here, there's one large supraauger cell and one large suprabullar cell. And then this cell that's all the way in front, we used to call type 4, that would just be a supraauger cell that's completely within the sinus. So just important, more than the terminology, is for you to be able to recognize these on a CT scan preoperatively so that you can make sure to address them. The supraorbital ethmoid cells are also something that commonly fools people when they're in the frontal sinus. They can get into this space. It's really nice and farly laterally pneumatized. They think they're in the frontal sinus, but in reality, they're one step back from the frontal sinus. And so really, you know, again, investigating your CT beforehand allows you to address this. So first, I'm just going to show you this primary frontal surgery case. And I want you to notice the tools I'm using. I'm using a lot of different types of instruments. I start with this frontal Kerrison rongeur just to take down this overhang at the middle turbinate axilla. And now I'm sort of moving just beyond the auger that I've already opened by taking my uncinate all the way up and showing myself the natural drainage pathway. Once I've shown myself that that's the drainage pathway, I'm going to very meticulously take out these little septations that are in my way within the frontal recess between where I am and the true frontal sinus. Now you can see I'm using a frontal Hosman, and at this point in time, my camera is below my instrument. That's almost never how we operate, right? In all the other sinuses, we always keep our camera above our instrument. But if there's a very anterior frontal sinus, putting your camera below your instrument gives you much better visualization of that anterior aspect. And then finally, you can see that we have a really nice wide visualized frontal sinus. And I want you to notice this meeting of the anterior and posterior table that you can see by looking up into the frontal sinus. That very acute area I call the horizon sign because of that shadow that's cast on the posterior table behind the, or on the anterior table behind the front, the posterior table at the back there. This is something that you will only see in the frontal sinus. You'll never see it in any of those other cells that I just talked about. And so if you keep going until you see this sign, you're going to be good. You'll have completely opened your frontal sinus and not missed anything. And I'll touch on that again a little bit more. What if you have a polyp patient? You know, sometimes you can't see all these little tiny septations very well because you got polyps hanging out all over the place. Well, really, it's the same exact technique, except first, you're going to remove all of that excessive hyperplastic soft tissue with a microdebrider or whatever other instrumentation. Remove this big mucinous degree of mucus that's kind of hanging out, hiding the natural anatomy. Once you've removed all that and skeletonized the natural septations and anatomy, then you're really able to continue and perform the frontal sinus opening the same way you usually would. And again, there's that horizon sign at the very top of the frontal sinus. So again, just to emphasize, the tools I use are various. It's almost never just sticking the debrider up there and taking everything down. That's not a good way to make sure that you have meticulous dissection. So you can use curettes, although again, I never fracture off skull base itself. You can use these graspers to just remove any bone fragments. Removing tissue that you have broken up or displaced is key in being able to continue your improved visualization throughout the surgery. And the final view, again, it really should include that horizon sign up at the top. You'll never see that. Any of those other cells, the supraauger, the suprabular, you'll always have a dome at the top of them. And so if you look up into a cell, even if it's really high, even if it's really large, if there's a dome and you don't have this really nice acute meeting of the posterior and anterior frontal tables, you're not in the frontal sinus. So moving on, why would we ever extend a sinusotomy? Well, the overall success rate, like I said, is really good, but 10 to 15% will eventually require revision. And the frontal sinus is the most likely to need revision. You can see that on short-term follow-up, about 2 to 11% of patients will need revision, but on long-term follow-up, which is over 10 years, up to a third of patients are going to need a revision of their frontal sinus. So that's not an insignificant amount. And you can see over here on this table, it's, you know, kind of logically associated between disease stage and surgical failure. The more aggressive the sinus inflammatory disease, the more likely you are going to need to have a revision. And there's lots of different reasons for this. I would say the most common reason I see in my practice is people just haven't completely dissected the frontal sinus. There's undissected cells, retained aggranasi, retained uncinate, mistaking those frontal cells for having been in the frontal sinus, mistaking those supraorbital ethmoid cells for being the frontal sinus, missing intersinus septal cells, things like that. And so that's actually great. That's the easiest thing to revise. You just go in and you remove all those cells and then you're in the frontal sinus. You don't have to do anything extra. You don't have to extend your frontal sinusotomy. You just do a good, complete frontal sinus dissection and you're going to be great and your patient is going to do really well. More challenging is when someone has been there before you and then created some sort of extra problem. So scarring or lateralization of the middle turbinate. This often happens when someone just removes the inferior portion of the turbinate and leaves that superior portion. If you're going to take the turbinate, you should take it all the way up to the axilla, because otherwise very easily will scar over and lateralize. There's nothing remaining to keep it standing out and medial. Recurrent polyposis, and this goes back to medical management, topical management, and then neosteogenesis, just out of control inflammatory response within the bone itself that can scar off, and you're going to have to address that. So the ways in which we extend the frontal sinus are just, basically drilling out more of the bone. So draft 2B, that's basically removing that sinus and superior portion of the middle turbinate all the way over to the septum. And then draft 3, which is also known as an endoscopic modified Lothar procedure, is really connecting both sides completely in a whole horseshoe. And the idea behind that is that you're really connecting the two drainage pathways together as one, and that there's just too much room there then for any amount of swelling or inflammation to completely be able to scar down the sinus after the fact. The indications for doing this range from just recalcitrant disease, like I was just talking about, to a huge frontal mucocele that you can't access from just one side, perhaps a failed osteoplastic flap, and we'll touch on osteoplastic flaps a bit at the end here, resection of tumors, like I mentioned at the beginning, and then fractures are often most easily dealt with endoscopically now through this type of approach as well. So here's just an example of a draft 2B. You can see this is an example where the prior surgeon did not take the entire middle turbinate, and that superior portion of the middle turbinate has now scarred over to the orbit and lateralized and is blocking the frontal sinus drainage pathway. You can see just removing that scar in and of itself gives me a lot of really good wide opening. However, I also know from my prior visualization of the CT that there's an intersinus septal cell medially that was not opened, and that is retaining mucus trapping in that area. And so this is performing a draft 2B, taking that middle turbinate all the way up superiorly, and then drilling out all the way to septum, so that now I have a nice wide opening of that intersinus septal cell as well. You can see that opening up there. And now I have a really nice wide drainage pathway of that entire frontal sinus on that side. You can see after the fact that heals really well. There's another sort of in-between step between a draft 2B and a draft 3, which is a frontal sinus rescue procedure. And this is actually removing the bone and the medial mucosal surface of a remnant turbinate, and then allowing that lateral mucosal surface to reline the roof of the sinus and nasal cavity. And that's when you have a lot of exposed bone. If someone's lateralized turbinate has created a lot of new osteogenesis that then you have to drill and you don't have any mucosa covering that, it's nice to have that lateral surface of your middle turbinate to just drape over that exposed bone. So that's something you can also do. So this is an example now of someone who has had 6 sinus surgeries before they ever get to see me. And you can see by looking at these images that they've actually had really good sinus surgery everywhere except that top frontal sinus. That's the only thing that's now obstructed. You can see it's almost a perfect dissection. You can't see any residual septations anywhere else in the entire sinus cavity. It's really just that top left frontal sinus. And so this is a case where you really do just need to completely open that drainage pathway. And sometimes the easiest way of doing that, here you can see that really granulated down opening, but this is the opening on the other side. And you can see that we have a really nice wide open frontal on the other side. So sometimes just connecting that really nice wide open frontal to the scarred off one is all you need to do to get that last sinus to be able to drain appropriately. When you're starting your draft 3, you can see I'm taking that superior portion of the middle turbinate. You don't have to remove your entire middle turbinate, and I would recommend not doing that because you'll get a really dry nasal cavity if you remove a lot of turbinate tissue from inside of it. But you can remove that very top part, and that directs you to where you're going to do your septectomy. You know, when you're doing your septectomy, it should really be right at the level of where you expect to transversely enter into that frontal sinus. You don't need, again, to make it a huge septectomy. You just need enough to get your drill or your scope through that top of your septum. Here you can now see that we're starting to drill in between that frontal beak area. And hopefully you can see that I'm really pushing anteriorly. I'm taking great care to preserve my cribiform and really even another like little extra dome around the cribiform plate. Some people will say using that first olfactory fillet is a good landmark to use as to how far posterior you should go. But in my mind, using that fillet, you've already sacrificed all the millions of olfactory nerves that are moving towards that fillet. And so I think it's better to actually use the posterior table of your frontal sinus as a landmark to see what your posterior aspect of the draft 3 is going to be. So what about balloons? I don't know on a worldwide scale how popular balloons are, or if it's just a US thing, but what I can say is that people balloon like crazy over here. And unfortunately, because it's a really simple thing to do, just pop a balloon and dilate it in the frontal sinus, and you get paid to do it, unfortunately, there's some overuse, some misuse of balloon sinusotomy in the frontal sinus here in the US. And I would just say that, you know, any studies up to this point looking at balloon sinusotomy in the frontal sinus, particularly in revision cases, really has not shown very good data. I would say that in particular for patients who just have a mucosal stricture, a little stenosing down on the mucosa, I think that's a perfect patient for a balloon. But other than that, often you should just go ahead and do an extended sinusotomy. So this is an example of a patient who I had seen in the office maybe a week before. They had had surgery on the outside, and then only this one frontal sinus seemed to have scarred down. So I decided, well, maybe it's just a mucosal stricture. We'll go ahead and try to balloon that open and see if we can, have this patient avoid needing another surgery. You can see here, I'm kind of poking and prodding around where the week before I had seen a tiny little opening into the frontal sinus, but you can tell at this point, just a week later, it's completely closed off. And so I'm just feeling around, seeing if there's any little opening where I think that I might be able to slip this balloon through. And finally, I decide, okay, there's the natural opening, but I don't really feel much of a opening. And you can see I try to deliver the balloon into the frontal sinus. And now you can see that it's just coming straight down at me. This isn't just a mucosal stricture. This is actual true neoosteogenesis that's completely occluded that frontal sinus from their last procedure. So that's when you decide, okay, it's time to do the actual extended procedure. I'm going to do an extended modified Lothrop. And again, we go to the other side, which seems to be very nice and open and clear. This is the side that has granulated down, scarred down with the drill. And you can see, again, just removing that superior portion of the middle turbinate, accessing through the septectomy, getting into that. You can see all that pus now draining out, and really then opening widely that scarred off frontal sinus. And once you know that there's this neoosteogenesis and that there's loculations within the frontal sinus, you really need to drill until you're all the way at the very top of the sinus. You don't want to stop just having entered into a space. It's very likely that you're going to have multiple loculated spaces within that frontal sinus, and you just need to drill completely wide open until you really, again, see that meeting of the anterior and posterior table all the way at the very top of the frontal sinus. Because if you don't, then even if you've opened up that little bottom area there, it's not going to be enough for people to get a really good resolution of their symptoms. So I'm just going to jump ahead because I know I'm slowly running out of time here. This is just a drug-eluting stent that I place now in all of my draft 3 procedures, because I realized that that little steroid elution into this area prevents me from needing to rotate any mucosal flaps in there at the end. The entire area just resolves really nicely on its own and resurfaces. And this is what you can see as the end result. So I'm going to skip through some of these slides because I think I'm running out of time. So I just want to briefly touch on the fact that we used to think an osteoplastic flap was the standard to revise any failed sinus. And now I would say the standard has really moved to endoscopic modified Lothrop being the standard that's going to be what you want to do to revise any failed frontal sinus. And there are some contraindications. Absolute would be if you have inadequate training, you don't know how to do it, you could do a lot of damage. You can really hurt the eyes, you can really hurt the brain. So don't do this procedure if you haven't been trained, or go get some training before you try the procedure. And then also lack of proper instrumentation. You really need very specific instruments to do this procedure well. Namely, a 30K drill burr is really what allows us to do this procedure really quickly and efficiently and well. Historic contraindications, what we call relative contraindications at this point. We used to talk about this AP dimension being narrow or the frontal beak being really large, but because we have these really great high-speed drills at this point, that really isn't a contraindication anymore. You just take that bone with the drill. It's really simple. It's really easy. You can make your own AP dimension, and that's how we do it. Now, needing to instrument a highly pneumotized sinus far laterally or along the orbital roof, like I mentioned at the beginning, that probably is a relative contraindication still, and you should consider whether you need any additional external approaches. You want to avoid complications, so know your anatomy, examine that CT in 3 planes, and again, you need familiarity with external approaches so that you understand and you can accept what your endoscopic limitations are. It's not going to be a situation where you're pushing yourself endoscopically because you don't know how to do anything else. So you should definitely familiarize yourself with all these other external approaches to the frontal sinus, so that if you need them, they're there for you. And just to end on that, you should keep your external skills sharp. This is a guy who came in to the emergency room with this big goose egg on his head. And you can see that, especially on the side view, how much that's poking out. This is a Pott's puffy tumor, but also he had this history of a car accident, and he had multiple surgeries in the past to try to reconstruct this area. And you can see this big plate is kind of floating above the frontal sinus, and that there is just infection below, in front of, behind, everywhere around the frontal sinus. And in this case, this is not something you are going to be able to get out endoscopically. You really need to do an open approach. So this is a bicoronal incision, just bringing the entire scalp down so you can address the frontal sinus itself. You can see this weird methyl methacrylate or some strange material that they just kind of gooped on the frontal sinus. So I pried all that off. And then in this middle picture, you can see this mesh that they tried to use to reconstruct. That's just completely infected with this necrotic fat, perhaps, that they put in to try to obliterate the sinus, but they didn't completely obliterate it, obviously. And so it became infected. So after removing all that stuff, you can now see in this bottom picture nicely down into the ethmoid frontal sinus outflow path. And then you can, drape that back and reconstruct once he's not infected. And this is what he looks like now. And he's much happier with his silhouette at this point. And then, post-operative care is really important. Biologics are a great new thing that we have in our armamentarium. And then working with our colleagues in allergy, pulmonology, all of our primary care doctors to really get to the underlying things which can make these patients recur if we're not addressing systemic issues. And with that, I will finish. Sorry, I may have run a little bit over there. This is my Instagram and Twitter if any of you guys want to ask questions after I have to leave, or you don't want to speak up now. I'm always happy to respond to questions on there also.
Wonderful. Thank you so much, Prof. Patel. That was really lovely, really comprehensive, really informative. I think everyone really enjoyed that. If there are any questions from the floor, would you kindly raise your hand? We've got a very full meeting tonight. Over 100 participants at the moment. I see that there are 2 hands raised. I'm going to ask Professor Libbe, who's from UCT. She's just raised her hand on one point. Darlene, would you like to unmute your microphone and just comment?
Yeah, thank you, Zara. It's a wonderful presentation and nice to see you again. After 2 years, can I just ask you, your endoscopic Lothrop, do you do it as a primary first-time surgery for your patients with the classic Samter's triad? Or would you first do try a full frontal Sweden ethmoidectomy and leave it as a second surgery?
Yeah, that's a great question. So good to see you too, Darlene. So I don't do it as a primary surgery, and it's primarily because we have all these additional tools now in our armamentarium where I don't feel like it's necessary anymore. So I would do just a really good, clean frontal sinusotomy first way, and then I get these patients after the fact on budesonide rinses, so they're getting really good topical steroid irrigation up into the frontal sinus. And I have them start immediately on aspirin desensitization, and now for patients that aren't able to tolerate aspirin desensitization, we get them on Dupixent, dupilumab, which, has just been a magical thing for so many patients. And so at this point, I feel like patients do so well with that combination that I have not really needed to go back on any for a long time.
Thank you so much. That's great. We don't have dupilumab available yet, but I believe from early next year, we'll have it available for these cases. So thank you so much again.
Good to see you.
Excellent. Thank you so much, Darlene. Prof. Patel, if you don't have to go yet, we've got one more raised hand.
Sure.
Can I ask Dr. Pierre, you've got your hand raised. That's not Professor Pierre, it's Dr. Pierre. Would you like to unmute your microphone and ask your question?
Hello, good evening.
Hi.
Teenagers about the age of 14 have extension laterally of the frontal ethmoid complex. How would you approach these sinuses, with the extension far laterally over the orbit?
So I would say it depends on whether you're trying to access sinus disease or a tumor. And so,
sinus disease, maybe polypoidal disease.
Yeah. So with those patients, I would say, often you're able to access that just through either a regular frontal sinusotomy using the correct angled scope or instrumentation. Using a 70-degree scope, you can see very nicely that far lateral. And if you have the right angled suctions, angled debriders, we have classically in a normal sinus surgery, I would just use my 0-degree microdebrider and maybe a 45-degree microdebrider, but we have 60-degree microdebriders, 90-degree microdebriders, which you can really use to access these very far lateral aspects of sinuses if you need to just get down polyps or things like that are obstructed. And so I would say just a regular frontal sinusotomy, or if I need a little extra room to get my instrument around the corner, perhaps a draft 2B just to get that middle turbinate over to septum at the base of the frontal sinus, something like that. I would say it's very, very rare that I would need to do a draft 3 just for straightforward sinus disease in a teenager.
We are not so fortunate with those instruments,
Yeah,
what do
I
you
know.
think
So
about
much
extending
depends
a
on what
limb
you
or a
have.
trepine?
Yeah.
Sorry.
And that's completely reasonable. I think, I think that's actually a great point to make, is that knowing the limitations of your instruments is key, and having familiarity with those external approaches. So definitely if you don't have the right instruments to get all the way over, knowing that you can just make a little external incision, little trephine, those heal really, really well. And so I think that that's completely reasonable if you don't have those other things available.
Thank you.
Fantastic. Thanks so much, Prof. Patel, for answering, and thank you for the lovely question, Dr. Pierre. Are there any more raised hands? Any further questions? We'll give maybe another 30 seconds. If you do have a question, kindly raise your hand so we can address it. Okay, I don't see any further raised hands. Prof. Patel, we want to thank you so much for your time and for creating the time. I hope it won't be the last that we'll hear from you and of you. I hope we look forward to a good relationship and a couple of great meetings. Thank you so much. We're going to allow you to get back to your clinical work. And
thank you so much for having me. It was really great.
Fantastic. Thanks, Prof. Patel. Okay, so thank you everyone for your participation. We're going to move on quite swiftly now. For our next presenter, we've got Dr. Frank Betances, who is from Spain, and he's going to be talking to us a little bit on an update on Meniere's. He's joining us very nicely from Lucus Augusti Hospital. But just before we allow him to join us, we're going to just ask Prof. Pierre if there's anything that you would like to add to his introduction.
Thanks, Louisa. I'm going to just share my screen just so that I can tell everybody a little bit about Frank. Frank, I'm going to try with your name. Dr. Frank Alberto Betances, is it Reinoso? I hope that's okay. And we're delighted to have you join us today. You come highly recommended from Dr. Carlos Shazia, who is one of our home favorites, who joined us last year for his observership in head and neck surgery. And so we're delighted to have a friend who's a friend of his. I believe you're a consultant otolaryngologist in the Department of Head and Neck Surgery in the University Hospital Lucus Augusti in Lugo, and that you have a special interest in otology as well as oral rehabilitation, and you've done a lot of work in children and in adults. And today you're going to tackle one of the hardest things that we have to deal with, and some of us choose not to. And so we would be welcoming any advances and updates in the management of Meniere's disease. Unfortunately, Francois is still trying to join us, and I hope that he will join us in a few short minutes. And he is also representing YO-IFOS today. So without further ado, I'm going to let Frank proceed. Thank you very much again for making time to teach us something today on Meniere's disease.
Thanks so much, Shazia. Frank, if you wouldn't mind to share your screen.
It's okay.
Looks fantastic. Go ahead.
Can you hear me?
Loud and clear, loud and clear.
Okay. I would like to thanks to Shazia and Francois to having me, to inviting me for these amazing sessions. My name is Frank Betances. I work in Spain, in the northwest of Spain, in the province of Lugo, in the University Hospital of Lucus Augusti in Lugo, Spain. And now I'm going to talk about one of my favorite topics, the Meniere disease, and specific, the diagnostic tools. 150 years after Prof. Meniere described the symptoms of complex recurring episodic vertigo, hearing loss, tinnitus, the diagnosis of Meniere was a challenge for the clinicians. Thanks to the Varani Society, the Japan Society of Equilibrium, and the European Academy of Ophthalmology, the American Academy of Otolaryngology, and the Korean Balancing Society, we have a consensus that give most easy to do the diagnosis of the Meniere disease. The consensus, the main idea is to do the diagnosis, drive to clinical presentation. The main clinical presentation are the spontaneous episode of vertigo, audiometrical document low and medium frequency sensorial hearing loss, and fluctuating auron symptoms. I have a problem with my, because it's moving.
No, we can still see your slideshow.
One moment, please.
No problem, no problem.
Okay. Okay. Okay, but it's okay. It's okay now. But the main problem is the temporal bone and the inner ears limit the diagnostic tool for assessment of the vestibular system. Postmortem histopathologic examination of human temporal bones have shown that many patients with classic Meniere disease have a distortion and dilatation of the endolymphatic space of the membranous labyrinth, a finding known as endolymphatic eardrops. These alterations are proposed to be the pathologic basis of Meniere disease. However, the correlation between these histologic chains and the clinical manifestation of Meniere disease is not absolute. How everybody knows, correlation is not causation, no? One of the landmarks about this topic is this paper published in the 1989 for Rounds in collaboration, and they find that some patients with idiopathic endolymphatic eardrop did not exhibit clinical Meniere syndrome. And these results challenge the dogma that endolymphatic eardrops per se generate the symptom of Meniere syndrome. We have a problem with this now because sometimes the patient with the Meniere disease don't start with all the clinic symptoms in the same time. No, some patients start with spontaneous vertigo, other patient with hearing loss, and other patient with fluctuating auron symptoms. That in this case, this patient going to be a challenge for the clinic. Because there is no gold standard for Meniere disease diagnosis, it's impossible to measure the performance characteristic of the various test methods. The classical dictum is that even in the best test, yield positive results in only 2/3 of the patients with classic Meniere disease. And here we go. Several tests have been proposed for the evaluation of Meniere disease patients. This includes BEMS, electrocochleography, autoacoustic emission, video nystagmography, video head impulse test, and magnetic resonance imaging. We're going to start with the BEMS, specific the cervical BEMS. The BEMS is obtained by the measuring the relation of the sternocleidomastoid muscle in response to ipsilateral auditory stimulus. The exact neural pathway is still not fully clear. The BEMS is considered to be a vestibulocholic reflex with the afferent limb arising from the sound responsory sensory cell of the sacrum. The fair report of the cervical BEMS in Meniere disease was done by Well and collaborator 50 years ago, a lot of time. And they find that almost 54% of the patients have an absent response. It's not too much power to do a good diagnosis. It's like a tossing coin, no? But Stephen Rausch and collaborators did a beautiful paper, a beautiful work. And they find that maybe it's not looking for the absence of the outcomes, maybe it's looking for the threshold. And they find that the patient with the Meniere disease have a up threshold that is different with patient with a normal hearing. And my Jean Lin in collaborator did a study that they proposed that the BEMS can be useful to diagnose asymptomatic saccular eardrops. And they find that the patients with the Meniere disease, like the other study, have a up threshold compared with the patient with the no affect hear or normal hearings. In conclusion, the BEMS may be used not only as a adjunct to predict the size of the disease, but also as a potential clinical detector of the presymptomatic eardrops, and thus may be used to predict the development of bilateral disease. Now I'm going to talk about the electrocochleography. The electrocochleography is a measure of the electrical potential generated by the cochlea and the auditory nerve in response to acoustic stimulation. The electrocochleography response may consist in a combination of the cochlear microphonic, the somatic potential, and the cochlear nerve compound action potential. We have two kinds of electrocochleography. One is intratympanic, and other is extratympanic. In the clinic, we prefer the extratympanic. Orchid and collaborator did a study with the transtympanic electrocochleography in Meniere disease, and they find that the patient with the Meniere disease have a elevated somatic potential comparing active potential ratio in 83.7% of the patients. But Pot and collaborator compare the other technique, the tympanic electrocochleography, but they don't have the same outcomes. They find the sensitive and the specificity of the electrocochleography in the diagnosis of endolymphatic eardrop were around 57 and 94%, a lot of random. In conclusion, the electrocochleography is often used in clinical investigation of hydropic condition of the cochlea, Meniere disease, but its diagnostic utility and interpretation remain in controversy. That the main clinical advantage of the electrocochleography may be the provision of ear-specific information. And the most important thing is in the electrocochleography in the patient with the Meniere disease is an increase of the somatic potential amplitude in relative to action potential amplitude. But a normal electrocochleography finding have not been correlated to the stage of the disease, the duration of the symptoms, the degree of the hearing loss, or the audiometric configuration. Therefore, the clinical utility of the electrocochleography for the diagnostic evaluation on this affects Meniere disease remains, rather is very limited. And now I'm going to talk about acoustic emission. It's well known that the inner ear disorder alter otoacoustic emission, and Meniere disease being an idiopathic endolymphatic ear drop disorder can induce alteration of the properties of otoacoustic emission signals. In this context, autoemission based evaluation may be used to monitor the entity of the cochlear damage or the evolution of Meniere disease. In 1985, Egermont and Schmidt suggest that the first stage of the Meniere disease, a variation of the outer hair cell function caused by the eardrops, may determine the typical hearing threshold fluctuation of the disease and may be indirectly registered as a decrease of the autoemission amplitude and the low emission frequencies. In more recent years, the Klein and collaborators suggest that the smaller autoemissions amplitudes in this ear affected by Meniere disease are probably caused by inner ear mechanical alteration related to the eardrops. In conclusion, the otoacoustic emission may be a reliable, non-invasive, and above low-cost method for monitoring the interior cochlear damage in the Meniere disease patients, particularly for monitoring disease progression. Magnetic resonance imaging in Meniere disease. Several years ago, it was impossible to do exploration of the temporal bone in live patient, but now, thanks to the magnetic resonance, we can look inside of the temporal bone. And in 2007, Nakashima was the first and do a study trying to look inside the temporal bone. He find that using intratympanic contrast is possible to check the temporal bone. But in only 5 years after the same thing, find that they can use intravenous contrast to check and do the same resonance imaging. Caloric and Meniere disease. The caloric test normally report around in the 50 and 66% of the patient with Meniere disease. But the calorie test with complement with the video head input test has assessment of the vestibular disorder and is most useful in suspect of endolymphatic eardrop. Asymmetric caloric function in the presence of normal horizontal head input test is more commonly associated with Meniere disease and may function as a diagnostic marker. And now, what trends we have trying to find a new marker to help us to do the diagnostic of Meniere disease. But one of my friends in Spain, specifically in San Sebastian, in Basque Country, is he find a new sign. The in ACE vestibular ocular reflex response in video hit patients with Meniere disease. This is my friend Jorge Rey, and he did this beautiful and amazing work. And the idea that he suggests is the increase of eye velocity response and heat impulse testing are a clinical sign that correlate with vestibular endolymphatic eye drop. He published a case series where he find that 2 patients with Meniere disease in 5 years doing the same test has a increase in ganache doing the video heat impulse test. And this author hypothesized that increases in hydrodynamic load that occur in the utricle and the semicircular canals during the lymphatic eye drops will produce an increase in afferent response during the heat impulse test. For trying to know if is true this idea, he created a model in 3D, a physiological model in 3D and through intelligence and through artificial intelligence. And the result of the physical computation model support the hypothesis that in the lymphatic eye drop condition, we are affecting the horizontal semicircular canal and ventricular region, and moderate dilatation can do a incremental gain values for over 1.1. This is the computational model. This is the model in a normal vestibular system. And this is a model in canal eye drops. Recently, the group of neurotology from the San Sebastian University Hospital published a new work doing a cross-sectional clinical study with the patient with the neurotology service, and trying to find if this new sign is present in all the patients with Meniere disease. And they find that the increase of burst response is present in this percentage, in very similar outcomes like the calorie test outcomes. But doing the search for this lecture, I find a nice paper. For me, it's my favorite paper because in some countries we don't have the same tools like video heat impulse test or video tomography because it's very expensive, and a lot of patients with Meniere disease have a sign that in a lot of paper is the second most common anomaly seen during the video tomography, is the spontaneous nystagmus. How come we can measure this? That using a mobile phone, and it's a cheaper way, I think, and reliable way to follow up the patients with Meniere disease. And when they do a crisis, maybe they can use the mobile phone to record the episode and trying to record the nystagmus. Yeah, I think it's a good idea. I would like to send regards to my friends in Dominican Republic, my colleagues, because I'm born in the Caribbean, in Dominican Republic, and I know there are some colleagues now watching the lectures. And especially to my team in the Lucus Augusti University Hospital. This is a beach in Lugo, Spain. If someday ones can come to visit us, are welcome. Thank you for having me. I'm sorry because I'm very nervous because it's my first time in doing a lecture in these settings. Thank you.
Thank you so much, Dr. Frank Betances. That was excellent. That was wonderful. Very nice presentation. No need to be nervous. I just wanted to have a look and see if there are any raised hands from the floor to see if there are any questions. I don't see any raised hands at the moment. We'll just give about another 30 seconds just to see. Okay, thank you so much, Dr. Frank Betances. We look forward to hearing from you again. Thanks very much for your help and your excellent presentation. I think if there's no further questions, we'll move on to our next speaker. Our next speaker is Dr. Samuel Okerosi. He is an executive chairperson of the Otolaryngology Head and Neck Society, which is a global initiative. And we'd like to be able to invite him to be able to do a presentation. Before he joins us, I'll just ask Shazia to find out if she wants to add anything to his introduction.
Thank you, Louisa. And thanks again, Frank. What we'll do is we can always let everybody know how to contact you if they have any further questions. Thanks for that wonderful presentation. I'm going to introduce you to Samuel Okerosi, and Samuel is actually one of the executive committee members of the Global OHNS Initiative. This is an international organization that advocates for ENT training as well as service delivery across the world in an equitable fashion. Samuel hails from Kenya, and he's currently an otolaryngologist at the, and I hope I say this correctly, Machakos Level 5 Hospital in the Machakos County of Kenya, which apparently has one of the highest burdens of disease for head and neck pathology, and it's one of the most rural areas in Kenya. So Samuel, thank you very much for joining us today and telling us a little bit more about the Global OHNS Initiative that you're an integral member of. So please, you have the platform. Go ahead.
Thank you, Shazia, for the warm introduction. You almost got it. It's Machakos.
Oh, I was so close, and I was going to say you had my name perfectly well. I'm so sorry. I'll try. Machakos.
No problem. Yeah, Machakos. I might just mention a thing or two about it during the presentation. Let me just share my screen. I hope you can all see my screen now.
Looks good so far. You can just put it on screen mode.
Yeah. So yes, as Shazia has said, my name is Samuel Okerosi. I'm one of the executive committee members currently acting in capacity of co-chair of the Global OHNS Initiative. I'm thrilled to be presenting in this forum for the young YO-IFOS. Especially because I think his name was Simmons. He presented in our forum once. Yes, so I come from, or I work at Machakos County, that is about 60 kilometers away from Nairobi, which is our capital city. Yes, we have a high burden of head and neck diseases. I'm not very sure if we have the highest, but it could probably rank up there. And this is just a photo of our hospital. And we are, you can see there that we do offer ENT services at Machakos. Sorry for the slight interruption. Yes, so we do offer ENT services at Machakos. Now about the global, I'm trying to move my screen, just a minute. Yeah, now about the Global OHNS initiative, it was actually an idea that sprang from the American Academy meeting back in 2019. It was during a session of the humanitarian section of the meeting where a group of ENT surgeons and residents began to think about the global health or global surgery perspective of ENT. And this is as a spring from the Lancet Commission. In 2015, the Lancet Commission on Global Surgery released a document highlighting the need to focus resources on a global perspective on surgery. This they did by providing some data on some of the issues that need to be focused on. For example, what they found is that about 5 billion people lack access to safe surgical care, and that is a big proportion of the world. Another additional 143 million surgical procedures need to be done. As they had done their assessments and their studies, they found that yes, we do about 313 million surgical procedures, but an additional 143 million surgical procedures are needed. And this is mostly in low and middle income countries. And as they focused the study, they found out that we needed about 2.2 million surgeons, obstetricians, and anesthetists as well to be able to adequately deliver surgical care. Now, this is all well and good, and it's actually very vital information because it can be used in planning. But the question arises on the perspective from an ENT point of view. How many additional ENT surgeries need to be done? How many ENT surgeons do we need globally? And those are some of the questions that important to have in mind as we start looking into the global perspective of ENT and ENT surgery. And just to drive the point home further, these are some of the questions that focusing on global surgery would be important to ponder. What is the current state of the global ENT workforce, for example? What are the ENT diseases with the highest burden globally? What's the current ENT infrastructure and what is the ideal? And for the 5 billion who lack access to safe, timely, affordable ENT care, what proportion of these patients are ENT? And as you think critically about these questions, you realize that we actually do not have primary data for ENT. So the initiative was founded now in 2019, and our mission basically is to advance the availability and accessibility and quality of global OHNS care through research and advocacy. We aim to be able to carry out good research to be able to provide primary data that will be used for planning and advocacy in ENT. I switch between ENT and otolaryngology, OHNS, because from where I am, we use the word ENT more often. Now, some of our objectives are I'll just summarize this into, we really need to know or carry out a needs assessment so that we can aim to have an element of capacity building. And we would hope to do this through collaboration. For the nitty-gritty of the exact write-up on our objectives, you can find it on our website, which I'll share at the end. This is just a heat map of the current membership that we have. We have about 150 members from about 48 different countries. And our primary focus is to be able to carry out good research to provide data and through global collaboration. So we've had a few publications. We've had the unseen burden of global burden of disease in ENT. We've also seen what is more global, or what is a more global health issue right now than COVID. So we've also had a commentary on COVID as well. There are current projects in the pipeline. Some of them, I think a few members who've joined this meeting are part of, but we are currently doing a Delphi survey, and we aim to at least try and get the 10 highest disease burden, ENT disease burden globally, and the 10 most essential procedures that an ENT workforce should be able to handle. This is actually in the manuscript writing phase, so hopefully it should be out, and everybody will be able to have a look at it. And one of our core agendas right now is to do a global survey on ENT workforce, ENT infrastructure, burden of disease and training and education. And this will be able to give us the primary data that we need for planning and also for advocacy. And then as you put people together in a group, you realize that people also have ideas on what would be important to research. And we also have a gender equity group who are looking into gender equity issues in ENT as well. We also have audiology with us. And there's a global audiology survey in the way together with the Lancet Commission. I'd like to highlight one other project which recently got published, and this was the Research Equity Guidelines. As a global OHNS, we thought, being that our primary focus is going to be research, we would really want to make sure that we have all participants in research well given a platform to equally collaborate and also to be well acknowledged as well. And the background of this is there are certain studies that have been done. The MITRI, for example, found that low-income country authors constituted 36.8%, 29.1% of senior authors, respectively. And this is based off publications of their home country, which may just show an element of inequity as well. And also, PAUYO found that surgical research for low-income countries, 24% of them, which is a quarter, actually only had high-income authors. And these are studies done in the low-income countries without necessarily the low-income country participants. So we would like to avoid this, and we think that coming up with the guidelines would be able to give us this so to say Bible to make sure that we include the publications, or we acknowledge every participant who participates in the initiative. So these are our guidelines. And just to sum it up is that we would really prioritize local representatives for any research work done in the particular country itself. And they would get priority for first author or first co-author. What I'd want to say is that these research guidelines are heavily mirrored on the Partners in Health research guidelines for Rwanda, and they have managed to actually get about 50% representative representation in their authorship for their publications with the local authors as well. So we would like to prioritize or make sure that local representatives form given priority as first authors. Authors meet early and discuss what their roles will be, and have their discussions laid out very well. And then all authors should have meaningful roles in the subsequent academic outputs, including the manuscript and authors, all of them have to satisfy the International Committee of Medical Journal Editors criteria. And the senior author or the senior researcher would attest to the veracity of the work. And so each publication would have to have a senior author who would be able to attest to the veracity of the work. Point number 7 is one that I really like, where the manuscript, which goes through the Global OHNS initiative, is actually reviewed by all members. All members are given an opportunity to review the manuscripts. And I think this is also a very good learning point or learning opportunity for anybody who is attempting to publish and to go through the global OHNS, because you realize the comments come and they are very helpful. Things that it's like having a form of peer review, but not yet submitted to a journal in a very friendly way. So it's a very nice, I actually like that particular aspect of the global OHNS. And the first authors also have priority to present their research at conferences. And as I said, yes, this was recently published. It's out there, anybody could borrow from these guidelines to try and achieve equity in publications. Now, how to join us? You can send us an email of your interest to globalohns@gmail.com, or you could visit our website, and at our website we have a contact bar, which once you click on it, you could fill out your details and ask to be included in the mailing list. So this is like extending an invitation to all the participants to join the Global OHNS initiative as well. We are also very happy to have been given this opportunity by YO-IFOS. We would look to collaborate more with YO-IFOS. Thank you very much.
Fantastic. Thank you so much, Samuel. That was very enlightening, and I'm hoping that you'll get lots of emails and will be overwhelmed with messages. So we would like to thank you so much for all your participation. We are actually well ahead of schedule. What we would like to do is we're going to move on. We're going to hand the floor to Francois, who's our Vice Chair of YO-IFOS. We'd like to invite him to tell us what the next webinar topics are going to be about, so that everyone can try and diarize that, and also to do some thank yous at the end. We've had a really good participant turnout, so much so that I think the system was actually quite overwhelmed. So we'll have to have a look and make sure that we haven't got any residual cappings, but we have recorded the session, and I will upload it to our YouTube channel for anyone that may have missed some of it. If there's bits that may have been missed and would like to be recapped, I'll certainly try my best to get the recording edited and loaded, hopefully before the end of the week. So that's basically it from the UCT ENT team. We really want to thank everyone for joining us. It's always a privilege, and it's always lovely to be able to host. Apologies if everything didn't run quite as smoothly as everyone would have hoped. These things do come with their issues. I'm going to ask Francois, do you want to just let us know what the next topic is going to be?
Thank you very much. So I wanted to thank you again also for this organization, which went really smoothly, and we look forward to the online replay, which is always very helpful as people can't always connect to the given time, especially from different countries worldwide. Special thanks, of course, to the speakers, to Zara, Patel, and Frank Reinoso for their great talks, and thank you also especially to Samuel for your inspiring talk. It's great to have these similar initiatives with YO-IFOS, and especially that we're not exactly on the same, we don't have exactly the same objectives. So it's really great to have collaborative work and support each other in this way. So thank you also again for your talk, and hope you get many people who send you emails. So as you said, we're gonna have a last webinar in 2021, probably around October. Actually, the topics haven't been selected yet. We're going to go over the topics which had been brought up during our first webinar. We're going to try and focus once again on probably the same time zone, which can try and get as many people as possible connected at the same time. So we'll be coming back to you very quickly with the topics. And a last issue, I just wanted to close on this, as I don't know if you followed on the YO-IFOS information, but we're going to publish the first special issue for videos, which is going to come out in 4 parts altogether. The first part is going to come out in the next weeks, and it's going to be focusing on pediatrics. So we'll have about 14 to 15 educational videos which will be published, and we're happy to say that we'll have 2 to 3 months of open access to be able to review all these videos. And then we'll have 3 other parts coming out, focusing on all the other subspecialties. So we'll be sharing this information with the newsletter. So thank you very much once again for having connected, and hope to see you in October.
Fantastic. Thank you, everyone. There's a couple of compliments saying thank you to all, and there's another comment just saying an excellent, outstanding gateway for all of us. So thank you for the lovely comments. Thank you, everyone, for joining us. Until we see you in October, we're going to end the meeting.
Thank you, Louisa.